Hello, everyone. Welcome to the second of the asthma series brought to you by the Office of Lifelong Learning and Physician Learning Program. I'm Denise Campbell-Scher. I'm the Associate Dean of the office, and our office is committed to bringing you the latest information, advice, and resources to support continued educational needs of healthcare professionals and teams. We just want to acknowledge that we're on the traditional territories across Canada of many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. This evening, we're very pleased to welcome back Mohit Bhutani, who'll be presenting the second of our series on asthma. Mohit is a professor of medicine at the University of Alberta. His main clinical and research interests are in the fields of asthma and COPD. He's currently the clinical director of the asthma and COPD clinics at the University of Alberta. Nationally, he's the co-chair of the Canadian Thoracic Society COPD Clinical Assembly and co-author of the most recent COPD guidelines. He's also the current chair of the Royal College of Physicians and Surgeons Adult Respiratory Examination. So today's topic is asthma gone wild, approaches to the management of difficult to control asthma. And I just really want to welcome you, Mohit. Thanks so much for coming back.
Great, thanks Denise, and thank you to everyone on the line today to join us again for a talk on asthma. Today, we're the second in the series of talks. Last week, we focused a little bit on the changing landscape on the approach to the mild and intermittent asthmatic, and gave you some of the demographics of how to approach, who these people are and how to approach their disease. And so today we're going to talk about patients that are a bit more challenging to treat and what you can do in primary care to try to help them achieve a better outcome. And so, the real objectives here today are to talk about the approach to the uncontrolled asthma patient, what you can do to sort of identify them, and then what strategies that can be implemented in order to achieve a better outcome for them. So that would be better day-to-day control and reducing their exacerbations. I'm really hoping that you walk away today and realize that I think we all know that prednisone is bad. I don't think anyone sort of advocates for anyone being on chronic prednisone for any condition. We're trying to liberate people from that. But I just wanted you to understand that it is really bad when it comes to asthma, and that even the first burst of prednisone is something that you need to mark and identify that patient to sort of implement strategies to change some of their outcomes. Because as we're going to see, the outcomes when you use repetitive doses of prednisone is quite impactful, negatively impactful to the patient. And then finally, we're going to talk a little bit about what severe asthma is, and how we as specialists can potentially help those patients that you may be struggling with in terms of options for their management, okay? So these are my disclosures, and nothing's changed in a week. So we're gonna start off again with a couple, three questions, and we'll ask the same three questions at the end of the talk. And so the first question is, what percentage of patients who are currently being treated for asthma do not have asthma when they undergo confirmatory testing? Is it 5%, 10%, 20%, 30%, or 40%? So the majority feel around 30% of asthmatics do not have asthma when they undergo confirmatory testing, and then a smattering of distributions, with 10% being the next most frequent answer. Okay, great. Next question is, when considering the cumulative dosage of prednisone, now the cumulative dosage of prednisone, how much total prednisone increases someone's lifetime risk of an osteoporotic vertebral fracture? So 5 grams, 10 grams, 15 grams, 20 grams, or 25 grams. And so 43% of people say 5 grams, 9% say 10 grams, 13% say 15 grams, and then 17% say 20 grams and 25 grams. So a bit of a distribution between all of the answers there. Okay. The last question is, which of the following tests do we not use to phenotype asthma? Is it total IgE, blood eosinophil, sputum eosinophil, alpha-1 antitrypsin, or fractional exhaled nitric oxide, FeNO? So which one of those ones do we not use when we're phenotyping asthma? Alpha-1 antitrypsin are 43%. So alpha-1 antitrypsin is 43%, and then sputum eosinophil is 22%. Fractional exhaled nitric oxide around 17%. Okay, great. So we'll come back to these questions at the end of the talk. So just to remind everybody and get a level set again, is that asthma is an inflammatory lung disease, and it's a chronic inflammatory lung disease. The eosinophil is the sentinel cell that's involved in this inflammation. And if this inflammation is left untreated, inadequately treated or is very aggressive, we see that there's structural changes that happen over the long term. And the disease goes from being a reversible airways disease to more of a fixed airflow obstruction, leading to more chronic symptoms. It has episodes of acute inflammation with the exacerbations that happen periodically based on exposures that a patient may undergo. This eosinophilic inflammation can be quite intense. And so when we look at patients who have normal airways versus those with more severe asthma, you realize that if this inflammation is left unchecked, you see very significant structural changes to the airway. So we see that the lumen in somebody's got more difficult to control their severe asthma, that there's more mucus in the airway, there's a thickening of the basement membrane, and there's more smooth muscle that gets deposited in response to the inflammation compared to someone that's got no inflammation due to asthma. And then you see that the airway is very wide and patent normally, whereas when it becomes more severe, it becomes more narrow, it becomes more small, and it's like breathing through a straw. And so that inflammation can become very intense for a certain group of patients. Luckily, we have good drugs, inhaled corticosteroids being the backbone of therapy for asthma. We have good guidelines like we discussed last week in regards to the approach to the implementation of the medicines. Yet patients with this disease, as we discussed last week, generally have persistent symptoms and they tend to exacerbate. So just want to highlight this data from the Alberta Health Services from what we experience here in Alberta when it comes to exacerbations. This data comes over 4 years, looking at emergency department visits where asthma is the first or second diagnosis. Over those 4 years, 90,000 hospitalizations for asthma over those 4 years. And again, a very staggering number when you see that number when it's presented to you in this fashion. It's around 20,000 emergency department visits every year for asthma exacerbations. The concerning part is that 20% of them come back within 30 days. And so if you can imagine, they get 50 milligrams of prednisone for 5 days here, and then 20% of them come back and potentially get another 50 milligrams of prednisone for another 5 days. So huge impact exacerbations on both the patient and the healthcare system when it comes to asthma exacerbations. And so the question becomes, who are these patients? Who tends to come into these in the emergency department? And the reality is that patients with all spectrums of asthma can exacerbate. And so when we look at a slide that comes from the British Thoracic Society, spectrums of severity of disease, BTS1 being mild intermittent disease to BTS6 being severe asthma, you realize that exacerbations as you age become more and more of a prominent feature, even in the milder category. So a third of patients between 18 and 54 years of age who have mild asthma exacerbate. More than 50% of people greater than 55 years of age in this mild category exacerbate. But then when you look at people who have more difficult to control asthma, the BTS6, you look at almost 90% of these patients have exacerbations every year. Okay, so 90% of these people are exacerbating, and we'll talk about what those negative outcomes for those patients can tend to be. So a huge burden to both the patient and the healthcare system. So patients that do exacerbate tend to have variability in their disease control on a day-to-day basis. And so we have good guidelines, and I'm going to go back to the GINA recommendations here. The Canadian guidelines for everyone on the line here is going to be available for mild and very mild asthma will be available likely at the end of the month now. But the GINA recommendations is what I'll stick to for today, is that we've got what to do for these patients when their symptoms become more progressive. And so these guidelines would tell you, or recommendations would tell you, that if you got symptoms less than twice a month, this is the strategy used for their treatment at that point. If they become more symptomatic, this is the step up, and so on and so forth, until you get to the very severe asthmatic population, which is where you've thrown everything but the kitchen sink at them, and they're still having either issues with their control, or they're exacerbating. So these guidelines are really straightforward in the sense that you want to step up to the next level of therapy for these patients based on what their symptom patterns are. But what we don't talk about necessarily in the step approach here is the step down. Our goal is really to get patients on the minimally effective dose of inhaled corticosteroid to give them the best outcome. Okay, so as much as we want to step people up when they're not doing well, we do want to step them down when they are stable and try to get them on the minimally effective dose that will keep them in that stable state. And so if you've got a patient who's having challenges with their asthma, whether it's due to symptom control or due to exacerbations, and you're deciding to step up, there's a few things that you want to do at the same time as you step them up to try to see if they're contributing to the poor asthma control. And then if you address those, maybe you're able to step them down, okay? As a caveat, if you're thinking about stepping patients down from therapy, the recommendations from Gina is right now is that they should be stable for at least 3 months before you decide to take them down. But I think if you're going to go down that pathway, you want to address these next set of factors along the way. So when I talk about these patients with uncontrolled asthma, who are these patients and how do we define them and how do you identify them? So this comes from the Canadian Guidelines on the Management of Severe Asthma published in 2017, and they define uncontrolled asthma as being patients who have at least one of the following. Patients who have poor symptom control, whether it's based on the control criteria based on their symptoms or using a validated questionnaire and using their scores to reflect poor asthma control. 2, if they're having frequent exacerbations, 2 or more courses of corticosteroids in the previous year. 3, if they've been hospitalized at all or been to the ICU. And then 4, if they have any abnormalities in their lung function. If they're below, their FEV1s are below 80%, then maybe those are people that may have uncontrolled asthma. And that's who we're going to talk about saying, in addition to stepping them up, what else should we look at, before we step them up, or simultaneously when we do step them up. So how do we approach this? So Gina's got recommendations in regards to what we should do. So before stepping up therapy, and I would say not before necessarily, but at the same time if you need to, because if you've got a symptomatic patient in your office, you're not going to wait. You're going to want to react and do something. But at the same time as you maybe step them up, or if you have time before you step them up, think about a few things. One, is it truly asthma that's driving the symptoms? So is the diagnosis correct? Is there inhaler technique and medication adherence appropriate? And have you looked at factors such as smoking and comorbidities that may be driving it? Because maybe more drug is not the answer. Maybe it's actually addressing these factors that will help you achieve better control. So the issue of diagnosis is an important one because all that wheezes is not asthma, and there's a long differential. And this is just a brief description of what potentially could cause somebody to wheeze or have to give the impression of wheezing. And so, I think one of the things that we're realizing more and more is that patients who are treated with asthma, we recognize not all of them actually have asthma. And so this proof of concept was established many years ago in 2008, when a colleague of mine, Sean Aaron from Ontario, did Canada's survey of patients with asthma, and they were self-identified, and essentially went through an algorithm to try to see, well, in their stable state, did they actually have asthma? And he would take them through an algorithm where they withdraw the inhaled corticosteroids and put them through bronchoprovocation testing. And he found out in this study that around 30% of patients with asthma actually did not meet the physiological criteria for it. Okay, so that's, we've always thought that asthma is overdiagnosed, but 30% was a bit of an eye-opener for us. And so this study had some criticisms, but certainly, told us that, and informed us that, maybe there is a problem here with the overdiagnosis. And so he got a grant and he redid the study. And a decade later, 10 years later, he published in JAMA, so Journal of American Medical Association, the reevaluation of diagnosis in adults with physician-diagnosed asthma. And he took the criticisms of the initial study and he tried to eliminate those or incorporate the changes that would reduce the criticisms. And so here's this algorithm of what he did is that, a study 1 visit, if they did not show reversibility of 12% in 200 mils, he'd bring them back a week later and do a methacholine challenge, a bronchial challenge on them. If they did not meet the cutoff for asthma, he would have the inhaled corticosteroids that they were on. And then they would come back in 3 weeks, redo the bronchial challenge again. Again, if they did not meet the methacholine challenge cutoff, he would cut off all their inhaled corticosteroids and bring them back in another 3 weeks. So a good washout period for the inhaled steroids, redo the methacholine challenge. And if they're still above 8 milligrams, then they would be diagnosed as having non-normal airway hyperresponsiveness and no evidence of current asthma. To address some of the issues that he had in the first study, respirologist got involved and he was sent to respirologists to have an assessment to try to find alternative diagnoses. And then he followed them up for a year, and a year later, and seeing if they would have developed asthma over that time. Maybe they just caught them in a period where maybe the asthma was a bit more quiescent. And he did bronchial challenges at 6 and 12 months. And again, 30% of patients in this study demonstrated that they did not have asthma. So one of two things. One is that we do know asthma is a variable disease, and maybe there was a spontaneous remission. So as you know, you've probably heard this for many times from your patients that had asthma that was bad as a child, and then during my 20s and 30s, it didn't really bother me so much, and now I'm a bit older and now it's coming back. That story is very common for us. And so there is spontaneous remissions, and based on exposures, that inflammation may go back. Or a cohort of these patients are actually don't have asthma, and there's alternative explanations. And so I think with asthma as a diagnosis, if you go back to your patients in your practices and reflect back on, have I ever had confirmatory testing for their asthma? If you don't have that in your EMR or your health records, I think it's probably worthwhile to get a baseline. The second thing is that if they're actually having difficulties with their asthma and their control is not that great, and if you want to step them up, that's fine. But at the same time, you want to maybe send them for spirometry again to see if it's actually any change in their lung function that might be indicative of the symptoms that they're currently experiencing. So confirming the diagnosis and using spirometry to help you better, sort of objectify that the pattern of problems within your patient is really significantly important. Just to remind everybody, what the diagnosis of asthma is on spirometry, we're looking for at least a 12% change in the FEV1 or FVC pre and post bronchodilator, and 200 mils, not just 12%, but 12% and 200 mils in either the FEV1 or FVC. Okay, so if you're doing it in office spirometry, that's what we're looking for. So confirming the diagnosis and then using spirometry to help guide management would be really helpful for you. Spending a few seconds on technique and adherence. And so the reality is this is a big problem. 60% of the patients that come to our clinic aren't using their devices properly, and about 75% of them are not using their medicines as prescribed. And it's a huge issue. And so, we can, whether it's you yourself that wants to teach your patients or review with your patients inhaler technique, or you send them to a certified respiratory educator, or you send them to a trusted colleague, you want to make sure that the patients are actually using their devices properly. And so what's important is that you actually send them to somebody who knows what they're doing. And so this slide comes from a study out of Australia, and I looked at Australian and Jordanian pharmacists. And so the thing that I want you to focus in on is what the pharmacists are doing and what the patients are learning. And so in this case, they're using the Turbuhaler, and they looked at, in this case, that 9 steps in the appropriate use of how to use a Turbuhaler. 50% of the time, steps 2, 4, 5, and 8 were being not done by the Australian pharmacists or Jordanian pharmacists. When they taught their patients, the patients learned, and they made the same mistakes in the same categories across the board. So again, if it's you who wants to do it, great. If it's somebody that you're sending them to, great. But at the end of the day, the person that's teaching really needs to know what's right. And we advocate for using certified respiratory educators, and a lot of pharmacies, have those educators available. So making sure we review it, because at the end of the day, patients are like anybody. They have an inhaler for a decade, 20 years, 30 years. Everyone likes to cut corners and be efficient, and those efficiencies lead to drugs not reaching where they need to get to. The other thing is compliance. And so what we realized, and we discussed a lot last week, is that the change in some of the strategies in mild and very mild patients is because we recognize compliance in inhaler with asthma patients is very poor. And this study just kind of hones in on that fact that over the course of a year, within 3 months after a new prescription of either an inhaled corticosteroid or an ICS LABA combination, by 3 months, under 50% of patients are using their inhaled therapies regularly. And by a year, that falls under 20%, okay? And this does not change. This is consistent data from all the studies, whether you go back into the 90s, the early 2000s, we see this regularly. And so if patients are having challenges with their control, really take the time to either phone the pharmacy to see if they're actually doing what they should be doing, or using Netcare and using the PIN data to see if they're being dispensed as the drugs are being dispensed as routinely as they should, because it is a massive problem. So before adding more or changing devices or changing inhalers, just making sure some of the basics are covered is critically important. To hammer in this fact, I really like showing this study because this comes out of the UK. And in the UK, they got a model where when they have severe asthma clinics, only respirologists can refer into this severe asthma clinic. And so when they found in their clinics a severe asthma clinic that takes patients with severe asthma only referred in by respirologists, When they saw these patients, they found that a third of the patients had failed less than 50% of their inhaled combination therapy. 88% of them said, yeah, we took drugs, but to their general respirologist. But when they came to the specialty clinic, 88% admitted to low adherence. And again, this is before the technologies we have now with EMR. So this is historical. And then 50% of patients were not even adherent to their prednisone. They confirmed that by measuring cortisol levels. So you can see that we are not even immune to this issue in terms of compliance. And you take the sickest of the sick and you realize that these patients are not even being compliant with their inhaled therapies. It's a problem. And I showed that slide last week that across the spectrum of disease, there's an overutilization of short-acting beta agonists and underutilization of their inhaled corticosteroids. So that is an easy, quick fix for you in your clinic when you're seeing these patients that are difficult to control. The other fact is, are there other aggravating factors that can make it? And I'm going to, there's many things that can aggravate somebody's asthma. Here's a list of a few things: smoking, environmental exposures, aspirin sensitivity. But I'm going to focus in on the smoking and on the sinus issues, because I'm a real big believer in terms of aggressively managing their sinuses to help improve their asthma control. Reflux is an interesting one. When we look at randomized controlled trials of patients that have difficult to control or uncontrolled asthma, and we randomize them to having a PPI versus not, there really hasn't been that impact of PPIs on treating every patient that comes in with uncontrolled asthma. I think the studies have shown that if you have reflux-like symptoms, treating those reflux-like symptoms can have an impact on your asthma control. But treating everybody across the board without having symptoms of reflux is probably not appropriate. And as we know, there's limitations on long-term use of PPIs. The other thing that's come out is that, we sort of think about non-acidic reflux. And so, patients that are having lots of nocturnal symptoms, and if you think it's, reflux, doing something like a 24-hour pH monitor wouldn't be unreasonable, or referring in for that testing to see if that's actually a problem. But on the whole, treating every asthmatic with PPIs really is not played out in terms of being beneficial for asthma control. The other thing that we see quite a bit of is, the impact of other diseases. So heart failure, COPD, if you have overlap syndrome, bronchiectasis, those kinds of things can make patients' asthma a little bit worse. And then really good evidence to say that, the psychology, the psychiatric aspect of this disease can be really impactful. So some good evidence that stress, depression, anxiety can impact the inflammatory cascade. And so addressing some of those problems would be really helpful. But, some of the things that I think one of the low-hanging fruits is looking at smoking. As we realize right now, the prevalence of smoking in the asthmatic population is the same as the prevalence of smoking in Canada. So anywhere between 18 to 20% of patients who have asthma smoke. And what we do know is that when you do smoke, there's a few things that happen. The inflammatory cascade changes. So it goes from being an eosinophilic inflammatory cascade to more of a neutrophilic inflammatory cascade. If that's the case, then we know that inhaled corticosteroids are not really as effective, because the eosinophil is very responsive to ICS, the neutrophil is not so much. So you have a changing milieu of inflammatory cells in the airway where the first step treatments may not be as effective. And there's some evidence to suggest that maybe in smokers, the prednisone in and of itself is less effective, and that's a bit debatable, but there is some suggestion of that. So if you got a patient who smokes and has asthma, really getting them, into a smoking cessation program, using things like QuickCore, I think are really helpful programs to help you achieve those goals. And it does have an impact. And so if you get patients who, with asthma, who abstain from smoking, you see that their ICS use goes down in terms of total dose. They use less beta agonists. They have improved lung function, and they have better symptoms, and overall they do better. So spending the time and trying to hone in on their smoking cessation is critically important. I'm very aggressive with sinus disease, and so I think asthma can't be under good control unless you treat their sinus disease aggressively. What we see right now is that the overlap between asthma and sinus disease, whether there's allergic rhinitis or chronic rhinosinusitis with or without nasal polyps, you realize that's a big proportion of patients suffer this, okay? And so I'm a matter of fact with my patients that come in with asthma, I put them on nasal saline rinses regularly, or at least I suggest that they should use it, whether they're symptomatic or not symptomatic. I think that, the chronic runny nose is an aggravator of patients' asthma. And so I think normal saline rinses are a low cost, high yield intervention, simply based on the fact that a lot of patients with asthma have allergic rhinitis and have more severe disease with chronic rhinosinusitis and nasal polyposis. So you see, these are big, big problems. And we collaborate very closely with our ear, nose, and throat colleagues to try to help address some of the things, especially when they have more aggressive disease, when the nasal polyps are grade 2, 3, and get their input in terms of how we best manage them. So what we do know is that there's a high prevalence of these comorbid conditions when you have asthma. The impact of this is quite important. What we do know is that patients who have chronic rhinosinusitis with nasal polyposis, they do have lower lung function. So when you look at epidemiological studies, asthmatic patients with in the brown and without in the gray, with chronic rhinosinusitis with nasal polyposis, you see a fairly significant reduction in their FEV1s and more obstruction. So they tend to have more inflammation, and they tend to affect their lung function in general. We also see that if you've got the comorbidities, there's an increased exacerbation frequency. So this comes out of the UK, and again, looks at patients with rhinitis, and then patients with nasal polyposis, and looks at if you've had 2 or more exacerbations over a 2-year follow-up. And you can see that the odds ratios of them having an exacerbation is around 14% higher if you've got rhinitis, and 60% higher if you've got nasal polyps in terms of having exacerbations. It even becomes more magnified if you're having 4 more exacerbations in the 2-year follow-up. Rhinitis and nasal polyps play even more of a critical role in this. And so I think aggressive management of their nasal polyps is really important. And it starts off in my clinic with nasal saline rinses. And then a trick I've learned from the ear, nose, and throat doctors is, if that's not enough to control their symptoms, adding in Pulmicort nebules mixed in with the nasal rinses. So 1 milligram and 2 mils mixed in with 240 mils of normal saline, and that's divided over a couple of, divided throughout the day in terms of nasal rinses. It provides irrigation and provides the anti-inflammatory that will help settle some of the nasal inflammation. And we realize that, again, when you've got sinusitis, so even a more problematic, more problems with having chronic nasal congestion, you see that, without sinusitis or with sinusitis, the rate of exacerbations go up. So, to me, good asthma control begins at the tip of the nose and involves really an aggressive approach with their sinus disease in a topical fashion. So, when you've looked at, the diagnosis, you've looked at compliance, you've looked at technique, you've looked at the comorbidities that might aggravate asthma, we advocate for a step-up approach. And so when you get to step 4, where patients are having more symptoms or they may have a loss of lung function, before you go to the high dose, you have an option of adding in tiotropium or adding in a leukotriene receptor antagonist or montelukast. And so after last week's talk, we were having a bit of a debrief afterwards, and something that Denise and I talked about last week, I just thought I'd bring it up because she thought it'd be of interest to the group, is that when you have this choice of what you want to add on to the inhaled corticosteroid LABA combination, if it's a choice between the LTRA and tiotropium, there's probably some important information to know. So one is about the montelukast and the fact that it's got a black box warning now. So this comes from GINA 2020. So the FDA in March 2020 put a black box warning on montelukast about the neuropsychiatric events, including suicidality with montelukast. So there's includes adults and adolescents. One of the common things that I've seen with patients when I put on montelukast is vivid dreams. And so whether you call them vivid dreams or nightmares, they can be problematic, and more problems in children, but we do definitely see that in adults where they just can't tolerate the medicine. And so the recommendation is that before you prescribe montelukast, you really want to consider the risks and benefits, knowing that this black box warning is there. And the FDA black box warning suggests that, really potentially restrict the use of montelukast to allergic rhinitis alone. I'll leave that with you guys just to know that this exists and that's out there, and that what that means to your practice. Personally, I think there's a very narrow window of using montelukast in asthmatic patients. We tend to use a lot of tiotropium. And the reason why that is because the study that was published in the New England Journal in 2012 that looked at adding on tiotropium in the Respimat delivery system to standard combination therapy. So tiotropium Respimat is the only LAMA, the long-acting muscarinic antagonist, that has an indication in Canada for asthma. And so, but it's in the Respimat delivery system for it. And so in this study, it was 2 studies kind of combined together. And basically what it showed was that in trial 1 versus trial 2 versus placebo, There was an improvement in lung function in both of them, 154 mils in one trial, 86 mils in the second trial, when it's an add-on to ICS LABA, okay? And they took a fairly sick population of asthmatic patients that were on medium dose inhaled corticosteroids that had low lung function, and they showed the benefit in the lung function itself in the FEV1. Bit curious as to why there's such a difference between trial 1 and trial 2. And if you read the paper, the authors don't really get into the details of that. But there is that curiosity here, but there's a bit of a difference in the FEV1 gain between the two trials. The same inclusion criteria and the same population of patients were included in both arms or both trials. But when they pooled the studies, the other thing they noticed in that time to first exacerbation, when you added on tiotropium, was reduced by 21%, and a number needed to treat of only 15. So, when we get to the patients who are step 4 of chronic symptoms, and before we move on to a higher dose inhaled corticosteroids, we tend to think about the use of tiotropium Respimat in this population of patients, and certainly we use that probably before we use montelukast at this point. So, why we do all this add-on therapy, why we're adding on, inhaled corticosteroids, why we're adding on things like tiotropium, why we're looking at all these factors of trying to improve asthma control, is because we really want to reduce the prednisone burst that patients experience. And so reducing this is a really significant importance. What we're realizing, and this is known to most clinicians, is that the chronic use of short-term, long-term oral corticosteroids has a myriad of side effects, right? So whether it's osteoporosis, risk of infection, cataracts, affecting your glucose control, obesity contributes to a myriad of things when people are on ICS. And what we're realizing is that the number of prescriptions of ICS in a year is impactful to some of the side effects of the inhaled or the oral corticosteroids that people experience. So this study out of the UK again looks at patients who had 4 or more OCS prescriptions in the year, and looks at their risk of developing complications of it. And on average, it's an odds ratio of 1.2. So if you had 4 prescriptions of an oral corticosteroid, short bursts of oral corticosteroids in a year, and the year following, you have a 1.2 chance on average of developing some sort of complication of the oral corticosteroids, whether it's osteoporosis, diabetes, GI problems, fractures, cataracts. So it increases with the number of prescriptions. And you may say to yourself, well, 4, that's a lot. And you're right, that's a lot. But as I'll show you in a few slides, there is about 10 to 15% of patients with severe asthma who continually have 4 or more oral corticosteroid prescriptions in a year. So this is not a large group, but it's a group that certainly exists, and certainly exists in databases. If the 4 doesn't thrill you, maybe the 1 does. So this study kind of demonstrates that in patients who have had 1 oral corticosteroid prescription for less than 30 days duration, okay, what happens in the 5 to 30 days after the prescription is done? And these prescriptions were being given for upper respiratory tract infections, allergy, bronchitis, lower respiratory tract disorders, or asthma, okay? And what it showed is that if you had 1 dose lasting less than 30 days, in the 5 to 30 days after you had this, okay, and the average prescription here was 5 days of 50 milligrams, the chances of developing sepsis, a venous thromboembolism, or fracture increases very significantly, where it's almost 4 times the likelihood of having an event where it leads to sepsis, which is massive. And so, it's not common, but it certainly, the risk exists for these complications even after a single dose. So you really need to think that, the oral corticosteroid, I might give it to them because it's salvage therapy and it gets them out of trouble, but it's got to be, you really got to think that this is the time to really intervene to start change the management so that we don't have cumulative doses of this. Because as we're understanding now, more and more, it's not just the number of prescriptions, but actually the cumulative doses of prednisone that are problematic. So this study was published a couple of years ago, and I like this graphic because it just sort of puts into perspective all the complications of oral corticosteroids. So this was a database review of almost 400,000 asthma patients in the UK. And essentially what they looked at was that patients were included on the index date of their first oral corticosteroid prescription. So as soon as they got their first oral corticosteroid prescription, they looked at the 10 years before and followed these patients out to 7 years afterwards, in some cases to 10 years afterwards. And it looked at the patients that got oral corticosteroids over that time frame versus those that did not. And their reference group was less than 0.5 grams. Getting less than 500 milligrams of prednisone over the course of the study was their reference group. And then he broke them down into groups of 2.5 to 5 grams, 5 to 10 grams, or greater than or equal to 10 grams over the course of the 7 to 10 year follow-up. And as you can see, the more prednisone you got, the higher your risk of developing significant complications. And these aren't, 1.05, 1.5. These are 2 to 3 times the higher the likelihood of getting, complications from the prednisone itself. And so in a wide variety of complications that exist. So it's not just the number of prednisone scripts, but the cumulative dose of systemic corticosteroids that patients are exposed to is now becoming more more in the limelight in terms of what it has in terms of impact on the long-term outcomes for these patients. So, when we ask the question of how much increases your total, how much prednisone increases your risk for a vertebral fracture. So this comes from the New England Journal of Medicine, looking at risk factors for fractures in patients receiving glucocorticoids. When they talk about related glucocorticoid use, cumulative dose of greater than 5 grams of prednisone results in an increased risk of developing a vertebral fracture. Okay, so if you think about it, you got a patient of 18 years of age who has 2 exacerbations per year, but otherwise is really well controlled in your assessment. 250 milligrams for 5 days, so that's about 500 milligrams a year. So in 10 years, you've increased this 18-year-old's lifetime risk of developing a vertebral fracture. If it's 1 exacerbation, so that takes 20 years. So at 28 or 38, you've increased this person's likelihood of developing, a vertebral fracture. So, fairly significant consequences as a result of the cumulative dose of prednisone. And so that's just prednisone treating for asthma. That's not prednisone being treated for their sinus disease. So when I, when I work with my ENT colleagues, they got bad sinus disease, they're putting on prednisone for 30 milligrams for 10 days. And so when you start adding up the different little pockets of where prednisone is being used in the asthmatic population, you realize that 5 grams is a very low threshold for people to reach. So, all the things we've talked about thus far is really to try to prevent that prednisone burst because you really want to reduce, their risk of developing complications from the systemic corticosteroids. So what happens if you've done all this, all the things we've talked about, but they still have poor control, poor quality of life, or they continue to exacerbate? What else can be done for these patients? So this is the step 5 patient, and these are the patients that are, have severe asthma. And again, from the Canadian guidelines, these are the patients who require treatment with high-dose inhaled corticosteroid and a second controller medication for the previous year. So there's step 5, you have them on the high dose, and you try to step them down because that's what we're trying to do. But anytime you step them down to a lower dose of inhaled corticosteroid, either they exacerbate or their quality of life is lost. Okay, so that's one group of people. 2 is systemic corticosteroids who are taking daily prednisone for 50% of the previous year to prevent it from becoming uncontrolled. So these are prednisone-dependent asthmatics. And then 3 are patients who are on either one of these therapies, but who remain uncontrolled. They either have symptoms or they continue to exacerbate. So these are the severe asthmatic population. Now, luckily, these are not patients that are a large population of asthma. So when we look at the percentage of patients who have mild asthma, moderate asthma, or severe asthma, the average, the number that we always quote is between 5 to 10% of patients would fit that severe asthma category. That, despite looking at their technique, their adherence, their comorbidities, we just cannot get them off of the high dose of the inhaled corticosteroid, or they still have poor quality of life. So a small group, but a huge driver of cost. Okay, so 61% of the spend on asthma care is on this small population of patients. So it is very impactful to both to the patient and to our healthcare system. Now you might ask yourself, who are these people that are on prednisone daily? Asthmatic patients who are on prednisone on a daily basis, or on oral prednisone more than 50% of the year. And I would agree with you. I've only seen a handful of these patients in my career. It's been 15, 16 years of being here in Edmonton. There's only a handful of these patients, but they must be out there somewhere because database reviews suggest that it's a fairly significant population. So the study looking at the Severe Asthma Network in Italy, they quote 64% of patients with their severe asthmatic patients are on daily dose oral corticosteroids. A study from the US and the UK says a bit of a number half that size, around 32%. But if you look at the literature, it's anywhere between 20 to 50% of patients who have severe asthma are on daily oral corticosteroids. And frankly, that's really got to change, because you've seen now the deleterious effects that systemic corticosteroids actually have. And so these patients that have severe asthma, they do have, even if they're on chronic daily dose oral corticosteroids, they continue to exacerbate. And so a study out of Canada last year, a survey of respirologists across Canada that took 4 patients in each of their practices who had severe asthma, and looked at what their pattern of exacerbation was in the year prior to the study. It looked at these patients were having, anywhere from 1 to 6 or more exacerbations per year, an average of around 2 to 2.5 exacerbations in the previous year. So severe asthmatic population still remains unstable. As a corollary to that, you realize they probably use emergency services even more. And it's kind of ironic, you take a look at, these people have 4 or more exacerbations, 6 or more exacerbations per year. They're visiting the emergency room every other month for their asthma. So it's a huge impact on the healthcare system. And as a result of that, they're using a lot of prednisone. And you sort of see that on average 2 to 2.5 scripts of prednisone in the previous year in these patients that have severe asthma. And so this population can be very challenging to treat. But there are options for them that have evolved. And these options that have evolved have come as a result of 15 to 20 years of really aggressive studying of asthma and understanding the different phenotypes of asthma. And so last week I showed this slide about the heterogeneity of asthma. What we now do is, when we get this population of asthmatics, we really want to phenotype them. And so whether it's mild or whether it's on the severe end, we really want to phenotype our asthmatic patients to start to see whether or not they have T2 type asthma, T2 inflammation, or non-T2 inflammation. The non-T2 inflammation is a smaller group, probably around 30% of patients with asthma, where the traditional allergic biomarkers are not really active in this population. These patients tend to be obese, they tend to have smoking associated neutrophilic inflammation, or they have some sort of other inflammatory cascade that aggravates the asthma that they develop. But the majority of patients fall into this T2 category, okay? And this T2 category, the understanding of the biology of what leads to T2 inflammation, again, has evolved dramatically in the last 15 to 20 years. And we realize that, patients that have T2 inflammation can have many different pathways that aggravate or that result in their asthma. So here's a slide and I don't mean to scare you with this slide, but this is what the reality of the world that we look at. So what hides behind, beneath the epithelium of the airway? You have airway allergens, viruses, or irritants that result in the chemotaxis of the eosinophil. But the resultant is that there's many different players that result in that chemotaxis that results in the asthma pathophysiology. And so the big players of this are IL-4, IL-5, IL-13, and IgE. These are the ones that play a big role in terms of asthma in general, in T2 inflammation, and the patients that have severe asthma. And so when we see these patients who are difficult to control or who have severe asthma and they fit the phenotype for T2 asthma, we have now biologics that we can use to target these pathways to help improve their outcomes, to reduce prednisone bursts, and to improve their quality of life. So, what we do recommend for everyone, whether it's in primary care or when they come to us, is really to try to phenotype our patients. And the things that we look at are the blood eosinophils, sputum eosinophils, their IgE, and their fractional excretion of nitric oxide. Those are the 4 things that we can do regularly. Now, sputum eosinophils and pheno are not as readily available. So sputum eosinophils occur in specialized centers. We at the U of A have access to a few, sputum eosinophil tests, not many. We're trying to work on trying to improve our ability to acquire these tests. In Calgary, they can easily do this. The other thing that we're looking at now is looking at exhaled nitric oxide and looking at it as a biomarker. A little bit of controversy around it in terms of how reliable it is as a marker, but you and your clinics can do total IgE, do specific IgE looking for the RAST panel, and then looking at the blood eosinophils to help determine if they've got T2 or non-T2 asthma. Because based on this, we can then offer them therapies. And so this is the Canadian guidelines for severe asthma. And so the building blocks are many of the things that we've already talked about. But once they get to the severe asthma stage, we want to assess their phenotypes with the tests that we've just discussed. And then we can implement some of the treatments with the biologics. And these biologics are really transformative medicines when used in the right patient with the right physiology. The ones that are available in Canada right now are omalizumab, mepolizumab, reslizumab, benralizumab, and dupilumab. So these are the mAbs that we use in asthma currently. And each of them have indications in terms of when you can use them or where they're best to be used, okay? And all of them have very good evidence in terms of their efficacy, their safety, and the response that patients have and who truly have severe asthma. So we can really impact them in a positive way and reduce their prednisone burden and also reduce or improve their quality of life. Just briefly, again, I don't want you to get into the details. As in primary care, I don't think these are the things that you need to necessarily worry about, but just know that if we put these patients on, these biologics, we're doing it with some semblance of security and knowing that it's beneficial for them. So omalizumab reducing exacerbation rates between 26 and 58% with an improvement in lung function. Mepolizumab, very similarly, improves lung function and it reduces exacerbation rates, 53% and 32% in the two different studies. Benralizumab, again, very similar reduction in their exacerbation rates in their two registration trials of Sirocco and Calima, and improvement in their lung function. So these drugs work very well and they work very efficiently in these patients. Our current challenge as specialists right now in this area is to determine which drug is the most appropriate for them, because we have these biomarkers for type 2 inflammation, the eosinophil, the fractional excretion of nitric oxide, and IgE. And the issue is that about a third to half of them overlap. So they've got patterns of inflammation that are elevated in all three categories. And so if it's purely eosinophilic driven, if it's purely acyl nitric oxide, if it's purely IgE driven, our choices are very easy. But when we have overlap, what is the right drug for the patient, and where can we get the best bang for our buck? Because these are expensive medications, in the order of $25,000 to $40,000 a year, and most of the biologics are for most of these chronic conditions, inflammatory conditions. But we want to make sure we're confident in terms of what we're choosing for our patient. And so at the University of Alberta, I belong to the International Severe Asthma Registry. So all of our patients are put into this registry, 6 sites across Canada, and then we collaborate with colleagues around the world. And we're trying to publish data in terms of trying to find out, what is the right phenotype for the right drug when it gets to these patient populations. But, for you in your day-to-day world, know that there's options that are out there, and that recurrent prednisone burst does not have to be the norm for your patients. And certainly if you got patients with daily dose prednisone, again, that does not need to be the daily norm for them. There are options for them, safe options, efficacious options that can improve their quality of life and reduce their prednisone use. So in summary, I think you just need to have an approach to the difficult or uncontrolled patient. So diagnosis confirmation and using spirometry aid you in your therapeutic assessment, or sorry, your diagnostic assessment. You want to make sure that you make sure that technique and adherence are really addressed, and that you look for comorbidities that might be driving it. In particular, I think sinus disease is a really important one to look at. I think prednisone, it depends if you look at the world, the glass half empty or the glass half full. Prednisone burst, yeah, you can say it's a failure of treatment, but you can also think of it as an opportunity to sort of take a step back and say, okay, why did they fail? What are the factors that have resulted in that failure? And what can we do to prevent that next prednisone burst from occurring? And have you addressed all of those factors in a chronic disease management strategy for these patients? And it may take, an approach. It may take, approach to reflect back on things you've already done, such as technique and action plans and those sorts of things. But, you can implement good chronic disease management strategies to reduce the risk of future exacerbations. You want to understand it's not just the prescriptions, the number of prescriptions now, the frequency of the event, but the cumulative dosing is really becoming important in terms of the long-term outcomes. And then lastly, for patients with severe asthma, we now want a phenotype, and you can do this in your clinics to better understand if they've got a T2 pathway or not. But certainly when you've got the severe asthmatic or an uncontrolled patient that's consistently causing you to have problems, you refer them in, because we've got good medicines that can improve quality of life, reduce symptoms, and reduce their prednisone use. And then, lastly, just, refer to a respirologist. I think, there's really no guideline. I don't think there's any right or wrong reason. I listed a few things down here that would say that these are reasonable things to consider for referring to a respirologist. But even if it's a second opinion, even if it's sort of say, hey, is there anything else going on? If you want to get your patients involved in research, there's often, any reason under, any reason under the sun would be, if you think it's warranted. I don't think there's a respirologist that would say that having a second look at a patient with asthma would be unreasonable. Okay, so let's go back to the questions here. And so the first question is, what percentage of patients who are currently being treated for asthma do not have asthma when they undergo confirmatory testing? Is it 5%, 10%, 20%, 30%, or 40%? Next question. Now, when considering the cumulative dosage of prednisone, how much prednisone increases someone's lifetime risk of an osteoporotic vertebral fracture? 5 grams, 10 grams, 15 grams, 20 grams, or 25 grams? Okay, so perfect. So 96% said 5 grams, and that's the correct answer, 5 grams. And lastly, which of the following tests do we not use to phenotype asthma? Total IgE, blood eosinophil, sputum eosinophil, alpha-1 antitrypsin, fractional exhaled nitric oxide. Which one do we not use? Not have access to, but do not use. Perfect, alpha-1 antitrypsin, right? So alpha-1 antitrypsin for COPD, not for asthma. Perfect. Thank you. I'll happy to answer your questions.
Awesome. Thank you so much, Mohit. So we do have, just to remind everybody, there's a Q&A box on the bottom panel, and Leo's kicked us off just by asking how long should an ICS LABA inhaler last, Mohit?
Yeah,
so just to remind us on that.
So that's a great question. I mean, so it's a little bit harder to sort of say how long an ICS LABA lasts, simply because of the fact that it depends on the dosing, and then also depends on what inhaler you provide them, whether it's an MDI or whether it's the DPI version of it. What you're kind of looking at is, if you put somebody on, any of the BID medications, you're looking for patients to use it regularly. And if it's a 90-day prescription, then they shouldn't be refilling it more than 90 days. It's them using that prescription regularly and using it twice a day or once a day, depending on what you do. So there's not really an answer like that, versus that with a SABA, where you can actually quantify it, because we say you shouldn't be using it more than 4 times per week. And so you get 200 actuations of a SABA in a salbutamol inhaler. So you can go 200 divided by 4. It should last you 50 weeks, in terms of having good control of your asthma. So the ICS LABA is a bit harder to answer.
Mm-hmm. And Carrie has a couple questions. So the first one was, would you still recommend that a person with asthma quadruple their ICS when symptoms are worsening, so if they have an acute URTI, prior to being able to seek medical care?
Yeah, so when you're developing an action plan for your patient, I think, it's one of 2 things. I think the most common feedback is to sort of say double the dose of your inhaled corticosteroid and seeing what the response rate is. And then, pushing the ICS dose depending on what that response is. So if you double the dose and you're not getting the bang for your buck in terms of symptom improvement, reduced short-acting beta agonist use, then you can go up higher on your inhaled corticosteroid. There's going to come a point, though, that you want to be careful in not letting the inflammation go on too far. And that will need to be individualized to the patient that you're seeing, and then sort of recognizing, when is the right time to intervene with putting on prednisone. But I think doubling or quadrupling the doses is a fair approach.
Okay. And then if a patient really dislikes using their Ventolin with spacer for their exercise-induced asthma, would it be appropriate to just use Symbicort as a rescue inhaler?
Yeah, it's a great question. So, Symbicort as needed should be part of a strategy using budesonide formoterol. So, the guidelines are very clear, and the GINA recommendations are that, if you're going to use budesonide formoterol as a rescue, then your maintenance inhaler should be a budesonide formoterol inhaler if you're on step 3. If you're using it as needed, budesonide formoterol, there are studies out there in your milder asthmatics. So there's one study that was published in Thorax that looked at budesonide formoterol for exercise-related symptoms, and there was effect that was there. But again, you want to sort of use that in an appropriate fashion in terms of the chronic management of their asthma.
Mm-hmm. And then Candy has a question.
Yep.
So if you have a patient with moderate or severe asthma that fails step-down therapy once, would it be appropriate to remain on their previously higher strategy long-term, i.e. not try stepping down again?
Yeah, so that's a great question. So, Candy, I think the first thing is that you want to wait at least 3 months to get stability. And if they step down and they don't have control, then kind of going back to those factors are, what are the reversible factors? Are there any interventions that could be added on, sinus control, compliance, technique, those kinds of things that maybe aggravated or led to the loss of control? Once you step them back up, I think the whole concept is that it never hurts to try, in the sense, because you're not going to stop them you're not going to stop the inhaled corticosteroid completely, and it's rare for them to step down and exacerbate. So they might have, the symptoms might not be as good, and they'll go back up. And the patients will tell you, if you step them down, doc, I didn't feel as good on this, so I just went back up, and very quickly they're going to get back that control. So because asthma is a variable disease, spring, summer was not as good of a time because their allergies were bothering them more. That step down happened in that time frame, and maybe fall, winter is a better time to try. And that the strategy is that during the seasonal variation, that's where it's worse, you're on a bit of a higher dose, and then you step down where it's not as bad. I think you're safe to trial that, but it's got to be individualized, and knowing that if you do step down and they lose that control, are there reversible factors that you can treat to help prevent that from happening again?
Mm-hmm. And then Carrie is wondering about if you have patients who have a known history of multiple asthma exacerbations, do you ever just do a prophylactic prednisone prescription so that they have one in their wallet?
Yeah, so for sure. So, part of our, the action plan is to, what to do with your inhalers, and then have prednisone at hand, because you can save the emergency department visit, which in and of itself is important as well. But in the big thing with all these action plans, whether it's for asthma or COPD, is that they need to notify you. They need to let you know that they've been on prednisone, because again, you got to take that as a moment of opportunity to strike, to sort of say, okay, you've been on your prednisone, what went wrong? How do I prevent this next one from happening? So I think the strategy is a good one to reduce healthcare utilization. And again, the pandemic has taught us a lot of things, that patients don't want to go into hospital if they can avoid it. So having those medicines on hand is important, but they really need to be sort of communicating with your patient to say, okay, you've had it now. What do I need to do now to prevent this from happening? What led to this, and how do we prevent this from happening going forward?
Mm-hmm. And then Teresa's talking about what we were talking about prior, Mohit, around so people who are wheezy. So they're post-viral, they're wheezy. When you measure the peak flows in the office, they are reduced, but they don't quite meet criteria for asthma. When you send them off for spirometry, it says clinical correlation required.
Yeah, good point. So it's a challenge, right? And so we were talking about this before, and I said, you can do an hour talk on wheeze alone and what to do. I don't think there's one particular strategy. So I think if you have a high suspicion of asthma and you send them back and you get this nebulous, it doesn't really meet the criteria for an asthma. We see this all the time. Patients come in, they've got a mild degree of, they have a mild degree of obstruction. They were reversed by 8% and 120 mils, and suggest but not diagnostic of asthma. So there's a couple of things you can do. If you got a high pretest probability, you can treat them, and you can and then see and repeat the lung function testing and see if there's any change in the lung function testing, which will help you confirm the diagnosis. Two, you could give them a peak flow monitor and have them go home and see if there's any diurnal variation with their peak flows over the course of the day, because maybe on the day they went to go test, they weren't as symptomatic as they are on other days. And that happens regularly. And so then, do you when they go home and they're maybe in their environments where they're exposed to things that might aggravate their asthma, you see the diurnal variation. Or three, you're considering it and you got a high pretest probabilities, referring them to a specialist and asking for a bronchoprovocation challenge and seeing if they actually do or do not have that. So those are what I would sort of suggest to try to take that. I mean, this is it's a common problem. And it's just that we're within these criterion of what is and what isn't, these hard numbers of 12% and 200 mils, and a methacholine challenge of 8 milligrams per ml. Those are hard numbers, but asthma is a variable disease, and it just depends on when you're testing them and what time of year you're testing and what exposures they're having can have a fairly big impact on the response that you see.
Mm-hmm. And then I think we've got just the last couple to wind up here. So Carrie is asking about the best place to refer young children for pulmonary function tests, and also the earliest you can refer children, just due to difficulty with compliance with the test.
Yeah, so I'll always say our lab is the best lab, and I think everyone who says otherwise is wrong. But no, I'm just kidding. I think so. Any accredited lab would be reasonable to send a child to. The minimum age though is 6 years of age is kind of where we sort of see where you've got a bit of a reference value for them, and two that they're able to follow along and be able to follow the instructions and do the test. Because if you haven't done spirometry yourself, it's not an easy test, and it's a very tough test to do. And young kids, it's always a bit of a challenge. So, any accredited lab in the province, and then 6 years of age would be the youngest.
Okay, and then the last word to Candy, who has a follow-up to Carrie's question. So are there studies for use of budesonide formoterol, which take pre-exercise before symptoms start in patients with predictable exercise-induced asthma?
Yeah, exactly. Yeah, so there is one study published in Thorax a few years ago that looked at this exact question, and it did work as well as the salbutamol in terms of comparator arm, in terms of relieving the exercise-induced symptoms. The only caveat with this is that if it's primarily exercise induced symptoms, again, I'm just going to kind of go back and say this has to be part of a chronic disease management strategy, and so building that into how you utilize the budesonide formoterol should be the chronic disease management strategy should be kept in play there. But yeah, there is evidence for that.
Awesome. Well, this has just been fantastic, Mohit. Thanks so much for taking time and doing all the teaching. And I'm hoping that when we actually get the new guidelines out, we can entice you back to talk about what's new, and hopefully all the participants found value in the session. And really encourage you, just please give us a little bit of feedback, just so we can understand where our audience is at. Yeah, and everybody have a really great evening.